Hello, everyone. We're talking about the valves today and valvular disease. So let's hear our case. An 82-year-old male with a history of peripheral arterial disease and mild stable angina began to experience an increased incidence of angina. He met with his cardiologist, who discovered aortic stenosis and left ventricular hypertrophy. So let's talk a little bit about valve abnormalities. So this guy was diagnosed with aortic stenosis. Valve abnormalities really fall into two general categories, either stenosis or incompetence. So stenosis is a narrowing or a constriction of the valve. So it's like a failure of the valve to open completely. If it can't open completely, it would obstruct forward flow through that valve, right? It's like narrowing the opening. This could be from scarring, it can be from calcification. There's a variety of reasons that you can get stenosis. An incompetent valve is a failure of a valve to close. So it's like an insufficiency would be another word for incompetent. You can have a leaky valve, or you can have valve prolapse that both kind of fall into an incompetent valve. So the leaky valve would be the one out of the two that actually lets blood have backflow. So if it can't close completely, there'll be backflow of blood through the valve. So this could be a disease like of the valve cusps, like an endocarditis. It could be a disruption of the supportive structures, like the tendinous cords, the papillary muscles, something like that normally supports the valve can get disrupted. Prolapse is when the valve itself balloons back into the atria. So by ballooning back, it kind of absorbs some of that energy of the ventricle, which kind of disrupts forward flow out of the ventricle and also kind of pushes back into the area behind it. So there's two big kind of general categories of valve abnormalities, and they can occur alone or together. But if there's ever abnormal flow through a valve, that's going to create turbulent blood flow. Turbulent blood flow makes noise, so it's going to produce a murmur. So you can actually hear some of this abnormal flow in some cases when you listen to the heart. So let's look at what this does to the heart. Oops, wrong way. Here we go. So both the narrowing and the leaky valve is going to need the heart to increase contractility to maintain cardiac output, either to push the blood through the narrow constricted valve or because the ventricular contraction is kind of squirting in both directions. It's not squirting all the blood forward. Some of it's going out the back door. So you're losing some of the volume that would normally be in your cardiac output. So if you are repeatedly stimulating the heart to increase contractility to maintain cardiac output, patients who are walking around with valve stenosis or leaky valves can develop cardiac hypertrophy, which would lead to diastolic dysfunction. Because as the heart increases the size of the ventricular wall, the capacity of the ventricle goes down and it's harder to fill that heart. For incompetent valves, it can also lead to myocardial dilation. So the regurgitant blood fills forcibly and it lengthens the fibers of the heart, which can decrease contractility because of the changes in the length tension arrangement of the muscle fiber cells. So the dilation would be in the atria if it's either tricuspid or mitral valve that are having this issue, and it would be in the ventricle if it's either the pulmonary or the aortic valve. So it's really the pulmonary and aortic valve incompetence that would lead to systolic dysfunction because the ventricle would become enlarged and have that weakening in terms of its contractility. Finally, in these cases where the valves become abnormal, I mentioned the turbulent blood flow in terms of listening to the heart, but turbulent blood flow is a hemodynamic stress on the heart. So patients that have abnormal valves can end up having progressive damage to their heart because of the nature of the blood flow going through it. So our patient had aortic stenosis, and they discovered left ventricular hypertrophy, which hopefully should make sense with what we were just talking about, that the increased contractility over time to push blood through that stenosed aortic valve stimulated the growth of the ventricle and made it big. But how does that relate to the original reason for coming in? He sought medical attention because he was having increased incidence of angina. So obviously the heart is an extremely well vascularized tissue, but it is almost a one-to-one relationship where every myocyte has its own capillary. So like one capillary per myocyte in the heart normally. But when the heart undergoes hypertrophy, angiogenesis does not keep up with hypertrophy. Okay, so as you develop all this extra muscle, you don't get the same increase in blood vessels. So if a healthy heart is one-to-one, someone with pathological cardiac hypertrophy is now having one capillary for multiple myocytes. What that means is, as the heart gets thicker, it also has an increased distance for oxygen diffusion. So in this case, hypertrophy is the cause of the ischemia. In almost every case where we talk about cardiac ischemia, we're largely picturing atherosclerosis, right? Vessels that have atherosclerotic plaque that have moved into the walls and have decreased the diameter, leading to ischemia. This is actually a different mechanism where the increased number of myocytes kind of grew beyond its blood flow and leads to ischemia. And it's important to know that both aortic stenosis and ventricular hypertrophy are by themselves asymptomatic, right? It doesn't hurt when your aortic valve is calcified. It doesn't hurt when your ventricle is getting thicker. You don't have symptoms. You have symptoms once these changes cause problems. So the increased number of myocytes was increasing for a while, and then it sort of got beyond the capacity of those little capillaries to get enough oxygen, and then the patient started having, a more severe angina, and that's when it gets discovered. So many, many times this is discovered pretty far into the process for that reason. Okay, so this guy's patient ordered a balloon valvuloplasty. So let's talk about this procedure. It is, as it says in your notes, a minimally invasive procedure to dilate the valve. In general, when you have valve problems, they can be dilated, they can be repaired, they can be replaced. This idea is kind of just what it sounds like. You typically go through the femoral artery, and it's a balloon-tip catheter threaded to the valve. Once you're in the valve, you inflate the balloon to dilate the valve. So you just kind of smash it open. This avoids having open chest surgery. This can be done just during a normal catheterization. In general, though, it does not have great long-term outcomes. Not surprising when you think about the mechanism of it, just jamming it open. It has very high restenosis rates, that the valve just comes back down and still is narrowed and constrictive. The danger of this procedure is that you can actually change the shape of the valve and worsen the condition. You can have an embolism where pieces of the valve or tissue break free. If the valve gets damaged by the procedure, then they will need a replacement. But it's such a minimally invasive procedure. If they're kind of debating this or replacement, they might, you could do this first, and then worst case scenario, you have to do the replacement anyway. If you see a patient with a valvuloplasty, they would just be on really minor lifting restrictions for about 5 to 7 days, and then they really go back to life as normal. So if you compare that to an open chest surgery for a replacement, you can see how this can be a tempting option. So the patient tolerated the procedure well. He was evaluated by a physical therapist. A thorough cardiac assessment revealed stable cardiovascular response, and the patient was given standard inpatient care for mobility and discharge planning. So really simple case, simple intervention when it works well. So let's talk about another valve case. So our patient was admitted to the hospital with fever and chills, anorexia, dyspnea, and cough. It's a past medical history of rheumatic fever as a child with resultant mitral valve regurgitation. So let's talk through the mechanism of that one for a sec. Rheumatic fever is a multi-system inflammatory disease secondary to a type of a strep infection. It can very commonly lead to rheumatic heart disease, basically having cardiac manifestations of this strep disease. It can lead to inflammation of all parts of the heart. If the valves become inflamed and scarred, then that can lead to kind of what we're looking at here. So when we're looking at all the different kind of layers of the heart, I just want to do a kind of a quick little review of the layers of the heart. It's good to look at this again and just make sure we've got the language as we kind of throw these names around in different kinds of disease. All right, so I'm going to draw this really anatomical for you. Okay, so here's the heart. Here's the ventricle. So this is all the heart muscle. See, heart muscle. And then this is surrounded by pericardium. Okay, so let's start on the outside and work our way in. This is the pericardium. It is a fibrous connective tissue. It's really not very stretchy, and it completely surrounds the heart. So it's the sac basically that the heart is sitting in. So inside of here, inside this outer wall, is the pericardial fluid. So pericardial fluid is kept within this sac. So if you would get an inflammation of the pericardium, it would be pericarditis. Inflammation of the pericardium. The big risk with pericarditis is that because it is this sac around the heart that's not stretchy, if fluid accumulates in that sac, you can end up in cardiac tamponade. Okay, so this is increased fluid in the, let me do a dot so it stays organized. Increased fluid in the sac, in the pericardial sac. And what happens is it actually compresses the heart. Because the pericardium isn't stretchy, the fluid squeezes the only thing it can, and that's the heart. So this is going to decrease cardiac filling, and this can acutely lead to a drop in cardiac output and actually lead to shock. So cardiac tamponade is a pretty serious medical emergency because the fluid will basically kind of like squeeze the heart closed, if you will, like put pressure on the outside of the ventricle so the ventricles can't fill. All right, so that's the pericardium, the outer connective tissue that completely encompasses the heart. Then the external surface of the heart is the epicardium. The external surface of the heart. This is made of loose connective tissue and elastic fibers, obviously real stretchy, the epicardium. The innermost, where the muscles live, is the myocardium. This is the muscle layer. Okay, so this is where the myocytes live. If you would get we'll stay in green. If you would get an inflammation of the myocardium, it would be myocarditis. Maybe we'll do like a yellow underline of all of our names of our inflammation. There we go. All right. Then lastly, the innermost layer of the heart, the area that like lines the inner heart chambers, is the endocardium. So that's this black line here. The endocardium lines the inner chambers of the heart. It also covers the valves. So the endocardium is the inside kind of, the walls of the ventricle, but it also extends, completely covers the valve, and it's continuous with the endothelium of the blood vessels. So an inflammation in any of those areas would be endocarditis. So because the endocardium covers the valves, when you get valve inflammation, it's called endocarditis. So this would be the name of valve inflammation. I think that one to me is the trickiest. The others, they really match their name. But endocarditis to me just does not sound like a valve problem. And I feel like I always have to go through the steps in my head to get myself there. So if that helps you, my brain works with cartoons. So this is something that I kind of mentally think through when I'm even saying these words to you guys. So one, let me see if this is on in your notes. So the endocarditis, I just have one of the more common, like we're talking about rheumatic fever, where you actually get an infection. So in this case of our individual, they would have had what would be called infective endocarditis. Really kind of tells you what the problem is, a microbial infection of the heart valves. In most cases, this is bacterial. And it is very tricky to treat because the valves do not receive their own dedicated blood supply. And that's really significant for two big reasons. One, our body fights infection, and please tell me you guys already know what I'm going to say here. Just say it out loud so you can feel really good. How does our body fight infection? We have to deliver the blood, right? To deliver the white blood cells. The acute inflammatory response. The whole process, really the goal is to get more blood to an area in order to deliver the white blood cells to get in there and eat up and attack the microbe that got in. Well, if you don't have a dedicated blood supply, you're not going to have this big local vascular response. It's very hard to get white blood cells in. So it's a hard infection for your body to fight naturally. And then that's also the way we normally deliver drugs, right? It gets circulated in our blood supply. So if you do not have a dedicated blood supply, it's really hard for the drugs to get there. To take an antibiotic and get it delivered to this area is really tricky. So it can be a very hard area to treat and can oftentimes lead to that valve needing to be replaced because you just can't beat the infection, basically. Okay, so our patient had this rheumatic disease as a child and had ended up, what did it have? We ended up with mitral valve regurgitation. So mitral valve regurgitation, if you kind of go back to that summary slide in the beginning, can lead to atrial dilation because the valve, bulges back into the atria and creating a bunch of pressure and can stretch it out. Can also lead to left ventricular hypertrophy because the energy of the ventricular contraction, some of it is wasted in that regurgitation back through the mitral valve. So the blood kind of squirting back behind you stretches out the atria, and it also impairs your ability to pump blood forward. So this was all kind of the past medical history little review. But our patient is admitted to the hospital with fever, chills, anorexia, dyspnea, and cough. He just happens to have this mitral regurgitation in the background. They took a blood sample, and he had bacteremia, bacteria in his blood. They did an echocardiogram that revealed endocardial inflammation. So our patient was diagnosed with this infective endocarditis of infective origin of the valves that are inflamed. So this is an image of an individual who had infective endocarditis, and they can attempt to treat, but for the reasons already described, it's very resistant to treatment. So they did try IV antibiotics with this patient, but he did not respond. It didn't really touch the infection. So a surgical replacement of the mitral valve is ordered. So for a valve replacement, first we'll talk about the surgery. The surgical approach is typically a median sternotomy. And they've gotten better with this, where they can do a mini, where they don't go all the way through, but a little mini sternotomy. They do have options for a kind of minimally invasive right anterior thoracotomy to access the ventricle, access the valve. Sorry, I got distracted by your notes. In this section, there's just a dumb typo in number 2. The first T in the, I guess not the first T, there's a TH. The thoracotomy shouldn't have a T after the C. In this case, that word suddenly looks like something totally different to you. But this is just cutting into the anterior chest, and it's mainly used for the aortic valve, access to the aortic valve. The types of valves that can be used can be either mechanical or tissue. So these are mechanical. There's a mechanical valve here on the screen. They can be metal or synthetic. This is like a ball and disc mechanism that opens and shuts in response to pressure. The ball and disc mechanical valve is extremely durable. It basically lasts a lifetime. So this is a more common choice for young individuals who have to get valve replacements because it really will last forever. Because it's not organic tissue, patients will have to be on lifelong anticoagulation therapy once they have this place. That's a pretty big negative. The other negative is that it can make a subtle but audible click because it's the physical moving of the ball. Patients can also do a tissue or a bioprosthetic. They can do a human would be an allograft, or an animal would be a xenograft. And for animal valves, they usually use pig, which would the medical term is porcine, or cow, and the medical term is bovine. These, because it's tissue, long-term anticoagulation is not necessary, which is a huge benefit compared to the mechanical valves. They estimate somewhere between a 10 to 20 year lifespan for the valve. So, traditional approaches to valve replacement are pretty invasive procedures. So, that's something to consider when choosing the type of whether or not you might need to repeat the procedure. Really exciting is that there is a newer procedure that now, when I first took over this class, is this my 4th year? This was like a brand new procedure that's barely being done. And now I would say more often than not, people are getting a TAVR, which is the transcatheter aortic valve replacement, as a non-invasive way to replace your valve. Let's let it think here for a second.
Tightening of the aortic valve, or aortic stenosis, is an indication for aortic valve replacement. In certain groups of patients, this may be performed with a transcatheter aortic valve replacement. Calcific aortic stenosis is shown here. The aortic valve is narrowed, and blood cannot flow easily into the aorta, causing pressure to build in the pumping chamber of the heart, called the left ventricle. This can damage the heart muscle over time and lead to symptoms of chest pain, shortness of breath, fatigue, swelling, and dizziness or lightheadedness. During transcatheter aortic valve replacement, A guide wire is inserted through a small incision in the thigh and up the aorta and through the stenotic valve. A balloon catheter is then passed over the guide wire. This balloon is inflated to prepare for the placement of the replacement valve. A catheter with a collapsed replacement valve is then inserted. Inflation of the balloon expands the replacement valve. A second type of valve replacement releases a self-expanding valve. The delivery catheter and guide wire are removed, leaving the functioning replacement valve in place. And allowing blood to flow freely out of the heart.
How cool is that? Isn't it amazing? So if you consider, hopefully at this point, you have an appreciation for all of the complications cutting into someone's chest. And that was really the only option for valve replacement. And now this is all threaded through the vascular system. It just absolutely amazes me. All right. So our patient had a typical, he didn't have a TAVR. He had a traditional valve replacement and it went well, and he was referred to physical therapy. So patients would typically be in inpatient recovery for about 4 to 7 days. A couple of days in the ICU to monitor blood pressure and heart rate and blood biomarkers. The nursing staff will walk the patient several times per day, but it's important to have PT on board for all the mobility planning. Anytime that a patient has a sternotomy, there are a kind of common group of symptoms that come with that. Really the biggest is the incisional pain. And this can impact mobility. It can impact definitely can impact their lung health because they're not willing to take a deep breath or cough. And that's why in this picture you can see her using splinting, although she's kind of showing an abdominal splinting, but splinting for coughing because of this. So the incisional pain, really leads to the respiratory pain because of the correlationship between the two. So they can have a lot of muscle pain, the muscles of the respiratory system, ribs, shoulder, back, and neck. We can really, work on having them use those muscles and kind of educate them on what their body went through. Wound healing issues is a concern, and it is primarily a concern for those individuals who have an underlying cause that would make them less likely to have good wound healing. So I think the wound healing aspect is sort of overblown because of the fears related to the sternal incision. So, we already talked about sternal precautions. Sternal precautions are in place to prevent sternal disruption. But if you really look at the data on this, of all the sternotomies, only about 2 to 8% of patients, 2 to 8% will have a sternal disruption. And almost all of those patients have an increased risk of poor healing, or have kind of wound healing issues. So the type of patient we're talking about are smokers, have a huge impact on healing. Patients with osteoporosis, because this is going to need their bones to heal. Patients who are on chronic steroids, and type 2 diabetics, because they have all the vascular disease. So, when you're thinking about how afraid you are of this big sternal incision and afraid that mobility is going to, pop this open, it's very unlikely. But if they have those underlying issues, those kind of comorbidities for that, then you can take maybe greater precaution. But I just wanted to put that out there because I think there's more fear than is appropriate given the incidents that we see clinically. So there's some psych issues, and then obviously the functional limitations are common. So to a thorough assessment, physical therapy intervention will primarily focus on early mobility. So PT will do a lot of education for these patients. So we already talked about kind of the standard sternal precautions, But I just wanted to include this schematic because this is a new way of doing sternal precautions. It's from this publication that's kind of refers to this as calling it as move in your tube, to educate patients of how to apply sternal precautions kind of in multiple settings. So they describe having if you imagine that you are wrapped in a tube, if you keep your arms within the tube, the activity is safe. So you can see this individual is using log rolling to go from supine to sit, and they're kind of keeping their arms in the tube at all times. This can be applied from going sit to stand. If you keep your arms in your tube, you can actually use your arms for your transfer to push yourself off of the chair. This is obviously different than the poundage restrictions we often see with sternal precautions. They typically say no more than 10 pounds for 6 to 8 weeks. The problem is patients are not being able to go home because they can't stand up without using their arms. And it is a huge issue that PTs are really on the forefront of this fight, trying to get more open-mindedness in sternal precautions. And whole big institutions have converted to this move in the tube. So when you're on your clinical, you might see this as opposed to traditional sternal precautions. And the big benefit here is that they can use their arms in mobility. They can use their arms, with an assisted device with greater poundage, as long as it is bilateral and within your tube. You don't want to be reaching out with one hand outside of the tube and away from you. So educating patients on whatever is the sternal precautions of your institution. You really have to follow what the orders are, but I just wanted to make sure you knew that there's movement here. And I think within your careers, if not in the next couple of years, this will be hopefully changing kind of more across the board. So safe bed mobility and transfers, how to effectively stay within whatever their sternal precautions are. So patients will typically be prescribed some aerobic exercise, the 3 to 5 sessions per week, 50 to 80% of heart rate, 30 to 60 minutes. This is all kind of standard aerobic exercise stuff, maybe a little bit longer warm up and cool down. But if they're pretty physically active and tolerating it, they can jump in. Resistance exercise is safe, 2 to 3 times a week, 10 to 15 reps, kind of standard protocol here. You want to stay within the limitations of their sternal precautions, obviously. And avoiding isometrics is to prevent that higher than normal blood pressure, which could strain the heart after the surgery. So again, it's really cool stuff and kind of complicated things going on physiologically. But then when we get to what we actually prescribe, it gets, right into our wheelhouse, and hopefully you feel really comfortable and safe in prescribing that type of exercise. All right. Thank you for your attention.